Good afternoon for everyone. My name is Eszter Szőke and my PhD thesis title is Aspiration in the Tracheostomized and Critically Ill, Diagnosis and Prevention of Complication Associated with Dysphagia. I'm a speech and language therapist and I work at Semmelweis Hospital at Neurology and Intensive Care Departments. And my vision is that speech therapists and physicians work side by side for their patients. And my mission is delivering evidence-based speech and swallowing therapy for all patients. I have 3 ongoing projects. You can see them. The background of them is that dysphagia is common among critically ill and neurological patients with a high rate of aspiration. It can cause pneumonia, a prolonged hospital care, or a slower recovery. It's very important if screening for aspiration lacks, the pneumonia incidence is higher. You can see there are several diagnostic methods for dysphagia. There are invasive and non-invasive methods too. My first project is comparing the modified Evans blue dye test to fiberoptic endoscopic evaluation for diagnosing aspiration in tracheostomized critically ill patients. It's the systematic review and the meta-analysis. About the fees. Fees is the gold standard for tracheostomized patients, and the blue dye test is what we are using in the intensive care unit to screening dysphagia. The missing link is the quality of the evidence of the blue dye test versus the fees in tracheostomized patients, and the aim is defining whether the blue dye test or the fees is the most reliable and feasible diagnostic method in tracheostomized critically ill patients. The clinical question is blue dye test as accurate as fees for assessing aspiration in tracheostomized patients? You can see there the PEERD framework and the hypothesis, which is blue dye test is not inferior to fees in diagnostic accuracy. We did the systematic search in 3 databases. You can see there the numbers and the search key too. Finally, we have 6 eligible full texts. The outcomes are the sensitivity, specificity, the negative and the positive predictive value of the modified blue dye test versus the fees. Let me start with the sensitivity. We included 6 studies. All of them are observational studies. All of the patients are tracheostomized patients. You can see the sensitivity of the modified blue dye test is 0.64, which means that 2 out of 3 cases the test tell the truth, so the patient really has aspiration. We have 2 outliers, the Phil and the Warnecke. They are performed the test at the same time. We did the risk of bias assessment with the QUADAS-2, which was recommended for diagnostic studies. The modified Evans blue dye test specificity is 0.89, which means that 9 out of 10 cases the test tell the truth, so the patient really don't have aspiration. The outlier is Belawski. Except of Belawski, the patient was weaned off ventilator. About the positive predictive value, the positive predictive value is 0.95, which means us that the blue dye tests confirm the true positivity of aspiration. And the negative predictive value is 0.59, which means us that the blue dye test is not confirmed true negativity of the aspiration. The articles had strengths and limitations too. The strengths are they directly informs bedside practice and immediately translatable into practice. But it's a relatively small and heterogeneous patient population. Sorry. About the conclusion, we have implication for the practice. If the blue dye test is negative, we need to do the fees. If the fees is negative, it means us that the tracheostomy tube can be removed and the patient can eat orally. If the blue dye test is positive based on the data, we can believe the test, so no need for the fees, but the intensivist can keep the tracheostomy tube in situ, and the speech therapist can follow or continue or start the swallowing therapy. We have a suggestion for the method too. We suggest that every intensive care unit need the modified Evans blue dye test, and we should do with 5 to 20 milliliter of sick fluid followed by the water. We need for blue dye test standardization and guideline for all intensive care units. The grade and the manuscript is in progress. My second topic is validating the Guggling Swallowing Screening test in tracheostomized patients. It's a drafting of a prospective observational study protocol. The GUSS test is a dysphagia screening test in stroke patients, and we have the GUSS intensive care unit, which is recommended for the patient who were intubated more than 24 hours. It's GUSS test is easy to use by nurses, for example, doctors or speech therapists too. The missing link is our critical care nurses and physicians as reliable as speech and language therapists in GUSS. The aim is assessing the inter-rater reliability of the GUSS at the intensive care unit and assessing reliability of the GUSS compared to blue dye test in tracheostomized patients. The clinical question is the blue dye test reliable regardless of professionals applying it? You can see there the PEERT framework and the hypothesis too. We include tracheostomized patients, adult patients, who are weaned off ventilator, but we exclude the pediatric patients and the patients who is unconscious. The outcomes are the aspiration diagnostic accuracy and the inter-rater reliability. My third project is the diagnostic accuracy of ultrasound dysphagia assessment as compared to fiberoptic endoscopic evaluation of swallowing study in critically ill and neurological patients. It's a systematic review and a meta-analysis, but its feasibility is undecided yet. But about the topic, the ultrasound includes the muscles related to swallowing, the tongue movement, the hypolaryngeal excursion, and the missing link is the quality of the evidence of the ultrasound versus the FEES or the video fluoroscopy in patient with dysphagia or aspiration. And the aim is to defining that ultrasound is as reliable as feasible diagnostic method for diagnosing dysphagia or aspiration. You can see there the clinical question is ultrasound as reliable as FEES or video fluoroscopy, and you can see that appeared framework and the hypothesis that the ultrasound is as reliable as FEES or video fluoroscopy. You can see there the planned submission date of the projects, and I would like to thank you for your attention. The beginning is always today.
Thank you for your presentation and the clinical relevance. My question is, in the GUSS test, there are those figures, but I can't really tell what are the meaning of these pictures.
So as I told you, the GUSS test is a screening test for dysphagia. The first means that we give the patient several consistency of food and liquid, and if the patient cough or has a wet voice or, for example, it means that he or she has aspiration. And the GUSS test recommends us if the patient can eat orally, or we need the FEES, or, for example, if we need the nasogastric tube. Yeah. Yes. So these pictures are mean that.
Okay, thank you.
If it's clear.
Congratulations, amazing results. Regarding the first project, I would like to ask that you said the limitation is the heterogeneity of the population. Do you think that the cause for tracheostomy can affect your results? So the indication for tracheostomy, the causes of...
Maybe causes about the background, the method, because the articles, all of them have different method and different time frame. For example, some of the articles doing the test at the same time, but some of them are doing 24 hours later, or sometimes it's not well defined. So maybe this is the reason why.
Okay, thank you.
Thank you for the nice presentation. My question is that if FEES is more reliable, what could be the reasons that we don't use it in every case?
Yeah, it's a good question. Thank you. I would like to ask you from the practice. In the intensive care unit, we have just one endoscope, which is needed for other cases. So if every specialist has an own endoscopy, it would be better. But for the patient, is uncomfortable to not just if we have or not. It's and they need some training before that. So who do the test, the FEES, they have to use it professionally.
Eszter, I would like to ask you, how can you interpret the data of Belavsky? Because along their data, the specificity of blue dye test is different from the others.
Belavsky, Belavsky was an outlier. We find differences in the method and in the time frame too. So Belavsky, in the patients in the Belavsky's article, the patients was not all of the patients was weaned from ventilator. So it can cause some problems, for example, and they are not doing at the same time the tests.
I think they were ventilated patients.
Yes.
Thank you very much.
Thank you.